You're up.
Good morning. Welcome to Kidney Corner. I'm Dr. Wendy Kindig. I'm a volunteer with the National Kidney Foundation of Indiana. And today we're going to be talking about pediatric kidney disease. And with me today I have Dr. Dan McKenney. Welcome.
Hi, thank you.
And he's from Peyton Manning Children's Hospital, and he'll be talking a little bit more about kidney diseases that affect children. So let's get started. I think most of the time, and we've had several other programs where we've talked about adult kidney disease, risk factors, concerns about progression, those most common forms, incidents, but I'd like to talk now because we don't normally think of kidney disease affecting children, but it does, and so I'd just like to ask Dr. McKenney, how common is kidney disease in children?
Well, it's not that common. The incidence is about 15 to 75 per million population, which is a fraction of what you see in adults. But it does have some importance because it's part of the population of chronic kidney disease, obviously in adults. And it may be under-recognized because kidney disease tends to be silent, and there's certain conditions that can cause kidney disease and affect growth and development over time. So it's an important disease to be able to recognize and to manage.
So in adults, we've said the two most common causes of chronic kidney disease are diabetes, number one, and hypertension is number two. So how about children and infants? What would you say, what are the more common problems there? Are they similar?
No, they're actually quite different. But the largest cause of chronic kidney disease in children is developmental or congenital abnormalities of the kidney and urinary tract. So these are conditions that affect the development of the kidneys and the structure in kidney filters, how the kidneys are perfused by the blood vessels, and how the urine drains, and so things that can cause obstruction to the urinary tract or development of kidney function can cause chronic kidney disease. And
so,
that accounts for about 50 to 60% of chronic kidney disease.
So that's by far and away the most common. And are those things that would be figured out before the child? We all do ultrasounds now during pregnancy. So is that something that they figure out before the child was born to be prepared for, or not?
We see a lot more of it. I mean, it can be picked up from prenatal ultrasound. So if there is an abnormality of the kidneys, it's detected. And actually, it's one of the most common abnormalities seen on prenatal ultrasounds could be dilation of one of the kidney urinary tracts, but you can also pick up if the kidneys are enlarged, or if there may be cysts in the kidneys, or if they're dilated, there's some evidence of obstruction. So a lot of this can be picked up prenatally.
Okay. And then for number two, what may be the second and third more common causes for children?
So some of the causes are similar to what you see in adults. The second most common would be inflammation of the kidney filters, like glomerulonephritis, that tends to have an immunologic cause, which is similar to some of the conditions seen in adults. There are certain hereditary nephropathies, so there can be abnormal genes or abnormalities in certain genes that are involved in the development of normal kidney cells, and the kidney tubules that over time can cause chronic kidney disease and affect kidney function. That accounts for about 10 to 20%. There's certain infections and toxins like hemolytic uremic syndrome that often will affect young children and can cause acute kidney failure and then subsequently lead to chronic kidney disease.
Okay.
And then children who are sick in the hospital or sick from a variety of different conditions, severe infections, illnesses, heart disease, when they're hospitalized in those conditions or have medications and things that can affect the kidney function, that can cause chronic kidney disease over time as well.
So that would be somewhat similar then to things that can also occur in adults. Okay. So what about risk factors? We talk about adults and we say risk factors are older age. Certain races are more likely to have chronic kidney disease. And of course, adult with diabetes or hypertension is at higher risk for chronic kidney disease. Are there certain risk factors then in children that we need to be aware of?
So one big risk factor would be is there a family history of kidney disease. So a lot of these congenital abnormalities of the urinary tract, there may be some family history that's similar to that can kind of be a clue to kidney disease in children. Certain cystic kidney disease can be inherited from generation to generation, so that could be a risk factor for chronic kidney disease in children. If there's a abnormal prenatal ultrasound, that's obviously what we talked about, could be a sign of kidney disease. Children who have urinary tract infections, that may be a sign of an abnormally functioning urinary tract that should be investigated for the possibility of an abnormality that cause the infection, as well as the infections themselves can cause damage to developing kidneys, which can result in long-term chronic kidney disease as well.
Okay.
And then hypertension, if it's picked up on just routine physical exams, high blood pressure over time can affect kidney function. It can be occluded kidney disease.
Well, let's talk a little bit about high blood pressure because there are probably 3 markers that we tend to follow in anybody with chronic kidney disease or even trying to diagnose it. And I kind of am curious to know, are there any differences between adult normal values and children? So the 3 kind of markers are blood pressure, measurement of kidney function, which is GFR, but basically that's a blood test that tells us how well the kidneys are filtering. And then the albumin excretion rate, which is just a check on the urine to see if there's an abnormal amount of protein being leaked out from the kidneys. So those are kind of the 3 parameters. And, adults, we say, well, and I think they're fairly similar in terms of the GFR marker and the urine protein marker. But what about blood pressure? We say in adults 140 over 90, it would be the kind of cutoff for saying this is abnormal. There's a few exceptions, and there are some lower pressures we shoot for in people who have chronic kidney disease. But you just said, well, checking blood pressure, you might find it elevated. What would be the normal range for children? Let's see if I can get that slide up. And this is a little complicated, but maybe you can simplify it for us.
So it actually is a little complicated, so it's not like one number, one size fits all, because obviously children range from infants to adult size. So the things that trend mostly with blood pressure is the older you are, the higher your blood pressure may be. Boys tend to have higher blood pressure than girls. The taller you are, you tend to have higher blood pressures. And then there's been studies that have actually looked at blood pressures in large populations of kids from infancy up to 18 years of age. And so there's these big tables that we pull normal blood pressures from. And they largely relate to your age, whether it's a boy or a girl, and your height.
Okay.
And with those 3 things, we have the 50th percentile, the 90th percentile, 95th percentile. And so we define high blood pressure in children as if your blood pressure is consistently greater than that 95th percentile for your age and your height. Okay. And there's large tables for that, there's apps for that we use, but it's important to kind of monitor those blood pressures and look at the blood pressure that you get for the size and age of the child. Okay.
So it looks like it's a little more complicated in children, but generally I think lower at a younger age and gradually comes up a little bit as you get older and larger. But there's obviously some fine-tuning there. So we're going to take a short break and we'll be right back. So what I didn't talk about.
When Margaret and I decided to sell the old estate here, we had only one choice in signage. Logan Street signs and banners. Conveniently not located on Logan Street anymore, but rather located on 10th Street on the south side of Noblesville. Well, we sold the old beauty, and we were able to buy this wonderful estate. And we had so much money left over, I was able to buy this beautiful 1968 Eldorado Cadillac for Margaret. Only 472,000 miles. Margaret loves it because it's got those big seats and that heavy-duty suspension to support her svelte frame. Next time you're looking for signs or banners, call old Jim at Logan Street Signs and Banners, 773-7200. Conveniently not located on Logan Street anymore.
So one thing that kind of came to my mind is concerns about transition from going to being a pediatric patient to an adult patient. And it does appear in the pediatric literature that that's actually a risk factor for progression of chronic kidney disease in a child. So one of my questions to you, Dr. McKenney, is, why might that be, and then what can we do to help change that pattern to improve it?
So the traditional way of following children in the past is that we might manage their disease, and we tend to kind of oversee how they're taking their medications and make sure that they're showing up for their follow-up and talking to the parents and make sure they're taking the medicines. But there hasn't been so much involvement of the child in that in the past. And so what happens is if you get up to the age where you're aging out of the pediatric range.
And what age is that?
Typically around 18, but
Okay.
sometimes a little bit more, maybe into college years.
Okay.
Certainly up to 18 and graduated from high school is the traditional time. And then that's a time where all of a sudden there's independence, you're free from family, you're free from regular doctors, you're responsible for making your own appointments and taking your own medicines, and we find that's a time where young adults may stop taking their medications or stop showing up for follow-up, and that allows for kidney disease to kind of progress, because we have less control over those things that might help to delay chronic kidney disease over time.
And so probably just starting to work on them to become a little more independent before the transition over to an adult nephrologist, and then trying to get them to take a little more responsibility. Obviously there'll be a subgroup that just don't want to do that no matter what,
Right.
but obviously there should be quite a few children that should be able to be educated and kind of trained to become a little more independent.
Right.
As long as the parents can accept that also, I'm sure they become quite attached to taking care of that child and being the one responsible. So unfortunately, if the kidney situation does progress and they go into kidney failure and it's not reversible, what are options in infants and children? I know certainly in the adult population we have hemodialysis can be done at home at a center. We have peritoneal dialysis and transplant. Are they the same options, or there's a different emphasis in the pediatric population?
So the options are the same. We are able to do hemodialysis as well as peritoneal dialysis, but our preference is to recommend peritoneal dialysis, because that's a procedure that can be taught to the family. It can be done at home. The dialysis is done on a daily basis rather than intermittently every few days. So that allows for adjustments and changes in the child's diet. It allows them to go to school during the day so they don't have to go to a dialysis center to get the hemodialysis done, because the peritoneal dialysis is, typically is done in the evening time or overnight while they're asleep, and then they can finish their dialysis in the morning and go to school. So we usually recommend the peritoneal dialysis.
So a little more normal lifestyle then,
That's right.
and a little easier to do, I'm sure, technically. So this is just a picture just showing, the slide was just showing where the catheter is placed. And we say peritoneal, the kidneys are a filter, so the peritoneal lining acts as a filter. In hemodialysis, we're actually filtering blood. So that's kind of the emphasis then. And then what about transplant in the young population?
Yeah, so the ultimate goal is for transplants, because we know that children who have a transplanted kidney do well. They have improved survival, they have decreased number of hospitalizations, their quality of life is better than if they're on dialysis, and overall development, health, exercise tolerance are all better with transplant compared to dialysis.
Now, there are some differences, obviously. We think of an adult and we get an adult kidney. What are some of the technical issues with transplant? How young can you go with, pediatric transplant, and are there some limitations?
So we kind of learned very early on as we tried to do transplants in children that were younger and younger, that we kind of, right around the age of around 2 or the size of about 25 pounds, smaller than that increases your risk for complications. When you put a larger kidney into a young infant, that increases the risk for surgical complications, clotting of the blood vessels that go to the kidney, so that the complications and failure rate are greater. So typically what we try to do is to wait till a child is about 20-25 pounds or more, and that helps for increase survival of the kidney and the patient over time.
Do you tend to have, is there a difference between the number of cadaver transplants versus living transplants? Certainly in the adult population, the deceased donor transplant is much more common.
Yeah. The living donor, particularly from a family member, is more common in children and actually accounts for about 50% of transplants in children.
Yeah.
And that has some benefits because it allows for the possibility of a transplant before a child ends up needing to be on dialysis, and that may have some improvement in quality of life and survival over time as well.
So does the same factors, so once they've had a transplant and they're on the immunosuppression to prevent their body from rejecting, is there also an issue with the transition from a pediatric, being a pediatric patient to the adult population? Is there also that issue about trying to get that in place solid and to have them taking more responsibility?
Yeah, so we run into some of the same issues in terms of the child's independence and taking medications and following up with appointments and things. That there is a higher failure rate of the kidney transplant in the late childhood years, like 17, 18 years of age, and in the transition to young adults as well. And some of that relates to compliance, but also some of that relates to the transition from the pediatric doctors to the adult doctors, and sometimes not being a good continuum of care for the child between those stages.
So is there anything you recommend in that regard for the continuum of care? Is there anything special you do when you're transferring a patient to an adult nephrologist or an adult internist?
So what we try to do is to make a connection early on with the one, educating the child and the family about their disease, but also connecting the doctor to doctor, the pediatric doctor with the adult doctor, so we have an understanding of what their care is going to be beyond the pediatric doctor's range, and the adult kidney doctor having an understanding of what the child has been through the past, what their goals are, how they've been involved in the management of their care in the past, and so they can kind of be able to assume the care and to help the child with their goals and the kind of things that they're wanting to get out of life, and how they can better take care of their kidney.
So it sounds like that's a process.
Yes.
It takes a while, and it sounds like there may be some patients come back to you for a while before they head back on over to the adult side.
Yeah, we find sometimes the transition may not be quite the right time, and so we have to maybe slow the transition a little bit or even reverse back. So you have to kind of individualize that to the patient. There needs to be some flexibility.
So, okay. Well, thank you, Dr. McKenney, and we'll be back in a minute and have another topic to speak about.
When Margaret and I decided to sell the old estate here, we had only one choice in signage: Logan Street signs and banners. Conveniently not located on Logan Street anymore, but rather located on 10th Street on the south side of Noblesville. Well, we sold the old beauty, and we were able to buy this wonderful estate. And we had so much money left over, I was able to buy this beautiful 1968 Eldorado Cadillac for Margaret. Only 472,000 miles. Margaret loves it because it's got those big seats and that heavy-duty suspension to support her svelte frame. Next time you're looking for signs or banners, call old Jim at Logan Street Signs and Banners, 773-7200. Conveniently not located on Logan Street anymore.
Welcome back. With me now, I have Tricia Behringer, and I have Beth Johnston. And so Tricia, she's a program director for the National Kidney Foundation of Indiana, and Beth is a nurse practitioner at Riley. And this segment, we're going to be talking about our kidney camp. So this is a program that started through the National Kidney Foundation of Indiana, but Beth was one of the founders, so I'm going to have you tell us a little bit about the history of camp
Sure.
and how the kids benefit and that sort of thing.
Great. So Nikki Howard and I were having lunch one day and talked about how great it would be for the kids that were on dialysis to be able to have a camp experience. Because when you're on dialysis, as Dr. McKenney talked about, it's something that has to be done every day and it requires training, so they just can't go to any camp. So the first camp was born 12 years ago. We did our first couple years at Bradford Woods, and I believe our first camp we had 7 children. And it was quite exciting, especially the morning that the hemo driver arrived to pick up the kids about 5:30 in the morning. So, but through the years, it's changed a lot. We, I believe, just the first 2 years were at Bradford Woods, and then we went to Camp Tecumseh. We found that most
Where is Camp Tecumseh?
North of Lafayette in Brookston, Indiana.
Okay.
So it's a fabulous facility. We found that Bradford Woods is really designed for kids that have a lot of physical limitations, but we find that most of our kids that are on dialysis and have chronic kidney disease don't have as many physical limitations. So they've really enjoyed Camp Tecumseh a lot.
So the benefit is just that a lot of these kids, especially the ones on dialysis, just can't really go to camp. How many days does camp last?
So the kids arrive on a Friday afternoon and they leave on a Tuesday afternoon.
Oh.
So I think that's 5 days, 4 nights, 4 nights of waking up frequently.
And so who can attend?
Any child with, we have kids that have just chronic kidney disease, so they don't yet need dialysis or transplant. We have a large number of kids that are on either hemodialysis or peritoneal dialysis, and then we also have kids that have been transplanted. And when kids have a chronic medical condition, parents need to feel really comfortable about who's taking care of them when they're away from their care. And so that has been good. A lot of parents, this is the only break they get in the medical regimens that they have to do for their kids.
And what's the age range then?
8 to 18.
Okay. Okay.
And we usually have, I think we're up to about 40 kids now, somewhere between 35 and 40 the last few years.
So Tricia, how do they pay for camp? What's the cost of going to camp?
Well, the cost is absolutely free to the children and the families. And so the National Kidney Foundation of Indiana does a great deal of fundraising throughout the year to help cover a lot of our programs, and especially our kidney camp. So included in that, we average about $1,200 to $1,500 per camper, just depending on some of their medical needs. But we bring in all the medical staff, have an enormous number of volunteers, many from Riley's. We have pharmacists from Manchester as well as Lutheran Hospital that help take care of the medical needs. And then so we run a kidney walk, several around the state to help cover our expenses for all of our programs, and we also do an annual gala that takes place in the fall of each year. I believe it'll be in October of this year. So all of the proceeds from these events help cover our expenses, and especially.
Okay, so that's great. So what are some of the activities in camp?
They do everything at camp. They do horseback riding, swimming, archery, Gaga, which is some kind of
what?
Gaga, some kind of pit ball game. It's the new thing, and they spend all of their free time doing that. Campfires, camp songs, cookouts, luau's, volleyball, just any kind of camp activity that you can.
Are they required to leave their electronics at home?
We do encourage that. Yes, we do.
Things that we've had to change a little bit because they like to take pictures and so forth.
Sure.
But
Right,
they
right.
definitely have
Limited access.
Yes.
Okay.
Zip line, that's always a favorite.
Yeah.
So.
So it sounds like there's plenty of medical staff that loved going to camp too to volunteer, so the kids are quite safe. So if there
Yes.
are any issues that they have to leave, there's always somebody that can escort them
Right.
or take them wherever they need to go. But
Right.
it sounds like it's a great opportunity for
It
the
is.
kids. Do either of you have any special memories from camp that you would like to share? Like any particular incident or activity, whether it just be something.
Oh, many. So my favorite thing I think about camp is to see the kids connect with one another. We had a little girl, or preteen, or early teen, who was really struggling with kidney disease and having to take all the meds associated and stuff. And she came to camp for the first time last year. And when she got home, her mom said, "This is a different child than I sent to camp." She's been able to take responsibility for herself, learn to do her dialysis herself. So that's the kind of change. I had another kiddo who was reluctant about coming to camp, and so had planned for his mother to pick him up on Sunday. And all week he kept saying, "Is my mom coming Sunday?" And I thought he was anxious to go, but actually what it was when she got there, he didn't want to leave. He was actually swimming, and he was one of our kids that was on peritoneal dialysis. And he came up and he said, "Mom, I don't want to go home. I want to stay." She just started crying. I'm like, "I'm so sorry you came." She's like, "No, it's worth it to see him swimming and having fun and not worried about this catheter in his belly."
Yeah.
So those are the really special memories. My favorite, though, was when we had a child, very active child, whose hemodialysis catheter fell out playing basketball last year. That was
That'd be
probably
kind of
one of the
exciting.
most
There'd be some
eventful
excitement
things we
there,
had
sure.
happen. But it is great. They have a wonderful time.
Yeah.
So.
So how about you?
You know, I think one of my favorites is actually related as much to the moms, because as a mom of children and how hard it is to let go of children, I'm very sensitive to what these parents must endure to let go of their kids and to allow us to take care of them and to entrust them. And we had one mom that just, she dropped him off and she left, and then she came back and she said, "Is he okay?" And I'm like, "Yeah, I think he's okay." And I just kept finding her standing in the window, like she just kept coming back. And so finally, I promised her I would send her a text a little bit later and show pictures and just assure her that he was fine. So sure enough, about maybe 8 or 9 o'clock at night, I walked down to the young boy's cabin and I knocked on the door and I said, "I'm just checking to see if so-and-so's doing okay. I promised Mom for an update." And said, "Are you talking about the little boy that's in the middle of that big circle dancing right now? Just having the time of his life?" I'm like, that's the one I'm checking on. Let me take a video. And Mom just was relieved. And now they don't miss a beat. They come to camp every year.
Yeah, so that's great. So how do you sign up?
So anyone that's interested in either supporting our camp or has somebody in mind that's interested in attending our camp as a camper, they can contact the National Kidney Foundation of Indiana. You can go to kidneyindiana.org, or you can certainly call me at the office, and I'm happy to answer any questions you have. So our camp will be in a few weeks, so the sooner we hear back from everybody, the better off we can get prepared.
Okay, so now Tricia, you're one of the program directors, so why don't you tell us about some of the upcoming events? I think we have the transplant games coming up.
We do. We have the Donate Live Transplant Games of America that'll take place in Cleveland, Ohio. This is a big festival sporting event that takes place to highlight organ donation and to promote awareness for organ donation. And we'll take a group from Indiana, probably a little over 100 individuals, that includes living donors, donor families, transplant recipients of all organs, and many supporters to go and represent Indiana at many of these events.
That
and
sounds like fun. Okay, and then we've got some walks coming up.
We do. We have our Indianapolis Walk on June 11th here in Indianapolis on the at the Indiana Historical Society, and we have another one in Fort Wayne. So we're always looking for volunteers and anybody that wants to come out and join us. It's free.
That'd be great, yeah. And I guess future events to put on your calendar, looks like the gala's coming up in October.
Yes, we will be, again, that's a big black tie affair that we encourage you to come out and help support. It's a great fun evening, and again, the proceeds from all of these events help benefit our services that we provide to patients.
Okay. Well, I think that's it for today. Here's our information if you want to contact us by phone or online, Twitter, Facebook, all the latest technology. And anyways, we'll see you back next time.